Okay, thank you very much. First of all, I would like to give thanks for who give us this opportunity to come and share and also to learn. That is the first thanks which I would like to extend. Next, I will give special thanks to my wife, who has given me the opportunity to spend 4 months, in taking care of the children. So I will give thanks for her and also the children, and other thanks for the center and the Brook community and Sanford faculty members who supported me. Thank you very much. So now I will go to my area is health financing and health insurance in Ethiopia, challenge and prospects. And the content is, I will give you some background, Ethiopia's health sector constraints, also research questions method, and policy analysis framework. I use the famous Wilson and Gilson policy triangle framework, and based on that, we developed some major themes using Nivivo. So I'll go that and challenge, that is the most important things. I find challenge and possible suggestions to address this challenge, how to scale up the scheme in Ethiopia nationwide. So Ethiopia, here you can see the colors, the 4 regions from Tigray regions, from Tigray on the north, which bordering Eritrea, and Amhara regions. Oromia region is the largest regions, and this is a southern people and nationalities region. The health insurance scheme piloted in these four big regions, and that constitutes the largest proportion of the population of the country. So economic-wise, Ethiopia has shown tremendous progress the last 10 years, progressing with on average 10% GDP growth throughout 10 years. This is an incredible result which Ethiopia has performed the last 1 years among India, China. Not only that, with respect to health, Ethiopia has achieved under 5 mortalities and maternal mortality. We have shown progress there, even achieved before we reached the end of Millennium Development 2015. And in this health spending, one of the lowest level of health spending in Africa, with annual per capita expenditure of $28. The WHO recommendation is around $60. But when we see in trend-wise from 1995, our per capita health is increasing. It started from $5, now it's reached $28. But yet, it is very low to achieve universal health coverage. Health sector constraint. What are the constraints Ethiopia facing? We can see the constraint from 2 sides. Despite the progress we have shown the last 1 decade, there is huge problem in supply side. What are the problem in supply side? Facility readiness. Even if when the project, this pilot project started, that's community-based health insurance scheme started, they conducted a case survey to see the readiness of the facilities. But during implementing, there are a lot of challenges and constraints faced. One, there is no adequate skilled manpower in health facilities at health post level, health center levels, and Woreda and the regional levels, and hospital levels as well. So there is also lack of drugs, medicines, and services. Those are the areas where the inequality in quality of health between regions and even within regions. There are variation within regions and across regions. The other one, the most important one, even if the government spending is increasing throughout the decade, but still it is very low. compared to the targets set by head of state in 2001, so Abuja Declaration, which states that states need to allocate 50% of their budget to health to reach universal coverage. We are at 11% now. We are approaching, but still below that threshold. So that is also a big challenge. From the demand side, outpatient health attendance is increasing, but still it is at 0.48 nationwide by 2015. More than 40% of individuals do not seek health care. That is, health-seeking behavior is low. We will see how the health insurance has brought some kinds of change. We'll see that one. In 2014, over 35% of the country's annual health expenditure was borne by individual out-of-pocket. Out-of-pocket expenditure is high in Ethiopia. So the last, from the 2010, it was highest around 50%. It's declining and now reaching 33%. But by WHO standard, it should not be more than 20%. We are at 33%, so still there are a lot to do. These are the major challenge which we identified through the Nivivo software. But when we finish the paper, we will further develop the constraints and others. Then Ethiopia has insurance scheme. Ethiopia, by understanding the context, the seriousness of the problems and the challenge, has developed the health insurance strategies and policies starting from 1998 and the health insurance policy in 2008 to improve healthcare and reduce financial burden of the population. The government launched a pilot community-based health insurance in 2011. It's initially rolled out the selected districts. We selected 13 districts to pilots, and by 2013 expanded to 160 pilot, and by 2017 we have reached around 340 districts out of 900 districts. So there are a lot of work to do ahead to scale up the scheme nationwide. So the government also started a social insurance scheme, but the social insurance scheme has not been implemented because of a big resistance from the population, from formal sector. So still now the government is struggling to initiate the social health insurance. My research objective is to examine why and how the health insurance became a policy agenda in Ethiopia. When we see the various field studies, assessment, evaluation conducted in health financing and health insurance in Ethiopia, the study focuses on patient practitioners at lower level. There is no input from policymakers. So there is a question in my mind. We have to see the perspective and opinion of policymakers, whether their policy, which they designed and implemented, what is their perspective on this challenge? So that is why I focus really on studying the policymakers. So I try to see that aspect, identify the challenge faced during the SCBHI and SHI policy process, whereas during the design, formulation, and implementation, and evaluation, and identify area of improvement. Research method. We use qualitative approach and also literature review. We conduct literature review, the most important review. We use Google and PubMed, Google Scholar, to identify by giving major teams and identify 55 literatures relevant. Then by studying and assessing the articles, we reduced to 33 key articles and used those as a secondary publications to analyze the research. And qualitative, in qualitative data collection, we use interviews, remote interviews from here, and we have interviewed about 18 policymakers from different sectors. And you can see that organizations, governments, about 6 multilateral, 5 multilateral, bilateral, and NGOs, 6. The NGOs are post-implementing partners, and also private sector, about 18. And we use the Nivivo 11 software and to transcribe all the data and coding, and it is working process, but we have used to develop the major teams and the type of policy. There are different strategies on policy analysis. There are about 4. The first one is retrospective and prospective policy analysis, which is we are focusing. And from this one, there is analysis for policy, which is a prospective ex ante. Basically, it will answer what will happen and what should be done. This is in a future oriented type of analysis. The second one is analysis of policy, which is a retrospective policy analysis, ex post analysis. What should happen? What happened in the past? What we learned? What can we learn? What difference has its brought? We could say. So my policy focus, analysis focus, this the second aspect. And what problem should be addressed? What is the solution to be the problem? This is where my policy analysis focus. This is the policy triangle framework. We applied Walt and Wilson policy framework. There are 4 things here. The center is actors. Could be individuals, organizations, groups. And what are their power, interest in this policy development, and the context what are the background context which helped or influenced policy formulation in Ethiopia? The MDGs, universal health coverage, and 2008 financial crisis, all this and others also affected the policy formulation process and influence it, and process-wise and content. In the content, we can see different kinds of dimensions, from cost dimension, effectiveness dimensions, efficiency, acceptability, those kinds. So there are 6 dimensions we try to incorporate in the analysis. And the policy actors are the main policy actors in Ethiopian context. The dominant is the government. From the government, the ministry, the parliaments are the dominant one. And regional health bureaus are also involved. Trade unions, Ethiopian medical associations, Ethiopian public health associations are also involved. From development actors, USAID and World Bank, Bill Gates and Melinda Foundation, WHO, FID, Guardian Global Fund. These are child 11. They formed 11 pooled donor or Millennium Development pool funding to support health financing in Ethiopia. There are also national, international NGOs, professional association, and community. You can see also the level of involvement decrease. The top is the dominant. When I asked interviews, some of the interviewers say that NGOs and donors in other African countries are the shaker and the movers. In Ethiopia, this is not the case. Though we are poor, we lead our program. We don't need donor interference. So they say this. So they are confident that they are giving a policy directions in this kinds of development program. What are the policy contexts? There are global contexts and the national context. As I mentioned, the World Development Report 1993, which states about health, investing in health, it says that government Ministry of Finance need to also give attention for health financing, because investing in health not only help health sector, also it helps to the overall economy. And after that, the developing country governments focusing attention for investing high in health sector. So the next one is the Millennium Development Goals, because based on Millennium Developments, countries are planning their national plan based on the MDG goals. That's also the other one is the universal health coverage, which report by WHO, and the other one, WHO consider health insurance promises a promising means of achieving universal coverage, because countries, they may not be able to mobilize more resources through taxation. There are huge resistance to increase taxes in developing countries. So the only other options, rooms they have, window of opportunity through health insurance. From the national context, the economic policy Ethiopia followed in 1991 after the removal of the Marxist regimes there. Ethiopia followed a mixed economy, and there was a structural adjustments program by World Bank. Starting from that, there is a liberalization of the economy started. Even the government, the health sector also started liberalization of the health sector. There is also another context. After 2000 election in Ethiopia, the government also brought the charities and society laws, which somehow prohibits NGOs in some sectors like governance and human rights area. That also a policy context. Health policy of the transitional government, also health financing, healthcare financing strategy 1998, also a context which shapes, and health insurance strategy 2008 define how formal and informal sector employees will be covered by prepayment and cost sharing mechanism. These are some of the background context. When we come to policy content, this is a fourth element in the policy triangle. We have seen these six dimensions: effectiveness dimension, equity, unintended effect, and cost acceptability, feasibility. And this is the summary of the interview responses. Out of 18 interview participants, 14 of them willing to respond on this dimension to give their subjective judgment. 4 of them, they decline. Their basis is that these kinds of analysis require objective type of cost-benefit analysis. Since it is subjective, they don't believe it will help. So I have to clearly mention that their reasoning. So out of 14, you can see that acceptability and feasibility of the scheme is moderate or high. There is no low kinds of rating for this feasibility. Effectiveness, there are 5 who have said it's moderate, and there are 7 who say it is highly effective. Equity, they're almost the largest interview participants say it is moderate or high. So this is just will give us their subjective perspective on the 6 dimensions. Based on the NIVIVO software, 4 teams emerged. The first one is the drive for Earth independence is pushing Ethiopia to increasing domestic spending. How government is really spending high, we will see with data and the response. Financial protection through prepayment and subsidies to address equity and poverty reduction goals. And increased enrollment in health insurance to increase health service access and utilizations. And the last one is continued political commitment at all levels required for scale up. Just okay. So these are the teams. Most of them believe that because governments, external donors, aid from external donors is declining, the country has to become financing its own program. The per capita spending, as I said, from 1995, it's increasing, but still below. We can see rest of the world by 2020, by 2010, it was 50% the share. Here, the share was 50%. After 6-7 years, now it's become 36. There is a huge declining of 48. Whereas the government spending, it was 16%, 1/6 by 2010. Now it is 30%. It is increasing, but it is not sufficient to cover universal coverage. So the second thing, financial protection for poverty reduction. Now it's out of pocket is reaching 33%, but we have to go be below 20% as well. Health recommendation. The financial protection reduction. You can see the general population, household expenditure on general or insured, between general population and insured. The general population is covering 240 for the insured one, it is very, very low. So the insurance is bringing a huge impact when we compare the uninsured and insured. The third one is increase enrollment. The enrollments vary above 50% in Ethiopia. The healthcare access is increasing and utilization is increasing because health system behavior is improving throughout. But how do we scale up and reach the national civic challenge? The fourth one is political commitment. There is political commitment at federal levels, but the political commitment when you go to the regions and the Warada and the Kabali level is a big question. So there is a legal framework which needs to be endorsed because there is proclamation which needs to be endorsed by the parliament, but it's delayed for a long time. So that is hampering the implementation. So there is a need for political commitment to endorse this one. And the resource mobilization, it's increasing. For the four regions, the Tigray, Amara, Oromia, and South, and the total, you can see it is increasing from year to year for the last 6 years after the implementation of CBHI. The major challenge, legal framework, I have already mentioned, the delay. It has to be facility readiness and risk pooling, because now currently it is at the Warada district level, but it has to grow to the regional level and central level, so that risk pooling become stronger and the scheme will not be a fragmented scale. So we have to work for that, and political commitment, leadership commitment at a low level. So human resources is an issue, and automation is, because everything is manual. Claim management is, reporting is very, very difficult at this stage. So they are really saying donors also need to develop, and partners also need to work on this area so that the country really once for all to suggest it. Government needs to speed up the endorsement of proclamation, facility to ensure quality of services, political commitment, continuous strong political should be in place, human resource, both skill and staff, automation, the IT system needs to be developed and installed, and Ethiopia Health Insurance Agency needs to galvanize support from developed partners to make adequate investment on IT system. This will help enhance efficiency. Thank you very much.
Thank you very much. That's a fascinating study and a beautiful presentation. And I see many of my students here, which is wonderful. Really great example of kind of the power of a policy analysis approach to understanding some of the successes, tremendous successes, and also some of the challenges in rolling out a health policy. Questions for Addis? Addis, come back. Okay. In the interest of time, we'll just take a couple of questions. I'm going to take the prerogative of asking the first one. The financial protection effects seem quite powerful, but I did wonder about affordability. How much are people in the community health insurance scheme? Presumably there's a premium and then perhaps some kind of a copay when you go to clinic. How much are people having to pay? And can you tell us what that means kind of as a percentage of their salary?
Oh, I think when we study the premium payments, around 39% say involving to the scheme is expensive. 39% of them. The premium is about 240 per. That means 214 per means
$10, okay. Annual or monthly?
Monthly.
Monthly premium, okay.
No, it's annual.
It's annual, okay.
Annual. 10%. They said it is expensive. So the government needs to reduce premium. That is also the bone of contention between regions. Regions say we need to decide premium ourselves, not federal level. Yeah. So that kind of harmonization requires
greater government investment programs to bring that.
So government, because the poor are unable to pay, the government is covering the indigent, the very poor, through subsidy. So government is giving 50% subsidy, but now he's planning to reduce, but regions affording it. So there are two types of subsidies the government's covering: general subsidies and targeted subsidies. The targeted subsidy is given by the Warada level, district level. And the general level subsidies from higher level. So that kinds of subsidies work in Ethiopia.
Questions?
I think at some point you mentioned how the population Ethiopians didn't like the insurance scheme, and I think part of it was probably because of the price. But was there another reason? And was the price just because of people who may not be able to afford it?
Yeah, absolutely.
Other reasons. The question was just: are there other reasons why people, why the scheme is not as popular with people as it could be, other than price?
Yeah, it's excellent. When you go to the social health insurance scheme, the formal sector totally oppose the insurance. First, the government facility, health facility, are not quality-wise preferred when you compare to private. So why I am forced to go to public facility? So insurance where there is no quality of service, so price is not.
This is a really fascinating theme in global health that you see a lot. You can have all these great ways of stimulating demand. You can give people cash. You can give them conditional cash transfers. Here's money, you can use it to go to a hospital or to get vaccinated or take your kids to school. But then on the supply side, if the service is not perceived to be high quality, people won't turn up.
Yeah, even now, during the interview, the big stations, they want to make the scheme mandatory. I asked them, when the government doesn't have a quality health facility, why it becomes mandatory? They say, we have to generate a resource, then we'll make the service quality. There's an argument between donors.
In the interest of time, we'll take two more questions. One, two. Can we get the next slides ready? Thanks, yes, great.
So does the insurance only cover if people use a government facility? And what happens if they have to go have, like laboratory tests or x-rays in a private facility? How does that work?
Excellent. Even the big challenge now, because the health facility readiness is not adequate, people, even if they are part of the insurance community-based health scheme, because there is no quality service, they are going to private health facility and spending additional resources there. And they are complaining. And they are now asking the Warada why they go to private, why they are insured. It's a big question.
The whole universal health coverage movement, this quality dimension has been somewhat forgotten, right? We think about coverage and financial protection and the package, but we have underappreciated quality. There is a new Lancet Commission on Quality in UHC, which will be publishing its report at the end of this year, that is trying to focus on that. It's really fascinating. Hey!
So I'm hoping I absorbed this right. So as I understand it, Ethiopia does not have a sort of Medicare / a very basic line. Like a lot of Latin American countries have a very basic public health insurance program that covers essential services. If I understand correctly, Ethiopia does not have a scheme like that. And if they don't, what do you think financially it's going to take to get a program like that off the ground? Because that's what's becoming popular in a lot of developing countries, especially Latin America, but in a lot of countries as well.
Yeah, we don't have such kinds of health Medicare type of scheme in Ethiopia. We have health posts and health centers where they are near to the communities in rural settings. We use it to the user fees for every service the communities benefited from those facilities. This one is this is a scheme is cheaper than the other possibilities.
There are so many different varieties, so many different pathways that countries are going towards universal health coverage. There isn't really a one-size-fits-all, in fact, as we see here in the United States. It's a patchwork. And for countries like Ethiopia and other countries that are still low income, most of Latin America is middle income.
Yeah.
These sorts of schemes, community health insurance where people are paying a small premium, social health insurance for formal workers out of payroll taxes are what a lot of countries are using, with some problems as we are hearing about.
Thank you very much.
Thank you very much, Daniel. The floor is yours.
Good afternoon, and thank you once again for the genre as well as my family for letting me off for this long, and the government of Karnataka, of course, because they have given me leave to pursue this sort of short-term stint at Duke and the Center for Policy Impact in Global Health. I'm greatly indebted for the fellowship that was extended to me, and thank you for Professor Shukla for having put me across to this. If not, then I was really not aware of this program like this, and thank you once again, sir.
It's true, we heard about you through GP, so thank you, GP.
And now, that was the relationship between Ethiopia and India would be, yes, we are similar in terms of income, and of course we have a long-standing relationship. We stole coffee beans from them. That's history behind it. My project, which I'm talking about, the research project which briefly I took about, was barriers to preventing non-communicable diseases in the state of Karnataka. And to all the friends who are not aware of the geography of India, India is a massive country. It's about 1.3 billion people, and we occupy almost 1/6 of the total population of the globe. And Karnataka is 7th largest state in the whole country, and then we're going to see a little of that. And then why was non-communicable disease a very important scenario for us is the question that I would like to answer first. The first one is the dubious distinction of India being called the diabetes capital of the world. The reason is 62.1 million people in the country suffer with diabetes, and 77 million people are supposed to be adding to this list with high blood sugar level. So you can understand the time bomb ticking. The second important thing is that 6 out of 10 deaths in the entire country happens to be on account of non-communicable diseases. And the chance that a person dying at the age of 30 and above dying is 26%, or quarter more chance increase in the death due to NCD. And 1 out of 10, the high blood sugar level is the 10% is the prevalence rate of high glucose blood sugar level, and about 25% of the population is supposed to have recorded a high blood pressure. And it is also the obesity is increasing. The WHO report in 4 years have found a 22% increase in obesity. So that's a phenomenal sort of situation. Though we have a high demographic dividend, it is roughly about 400 million people, including the population of the United States, to be in the productive age. But still, if this is the situation that we are in for a greater trouble. And the alcohol consumption, tobacco consumption is seriously high, and the report says about 5.2 liters per liter is a consumption of alcohol, as against the Southeast Asian region consumption is about 3.2 average. And the younger generation itself is also in a greater trouble, because 2/3 of these population between 11 to 17 do not have a good physical activity. That means you're almost glued to your desk. And so all these are something which always are a greater pointer for us to see that it is time we looked at in a serious magnifying glass that this problem is. And the second important substantiation for my statement would be the comparative statement we just got about the Indian Council for Medical Research, the apex body for medical research in the country, in 2017, late December, published a huge report on nation within nations, because each state here is almost equivalent to that of a nation. And the disability adjusted life years from 1990, which was more dominated by the communicable, maternal, neonatal, and nutritional diseases, And when you come to 2016, the whole thing gets swapped with NCD, the non-communicable diseases. And the deaths also caused because of this situation was on account of communicable and other maternal and child health was about 27%. And it's an alarming rate of about 61.8%. Like I shared, 6 out of 10 deaths is on account of NCD. The NCDs, as all of us, I'm sure, it's just to brief what are all the NCDs that we are looking about when we tell. And here, this particular study takes care mostly on the first two aspects, that is diabetes and hypertension, which is the most prevalent situation that we are in. And of course, cardiovascular and cancer on the second round of the whole understanding. As the international agenda was setting on NCD, when United Nations was bringing it as an of the General Assembly, as NCD conferences were bringing in, then you have the high-level meetings of United Nations going on. The country of India was also signatory to many of these the corporations that we are in. So the first thing is in a need to achieve the Millennium Development Goals. The first National Rural Health Mission was started in 2005 as a dovetailing of the RCH1 program, which was then the World Bank assisted project. Then in 2008, the first call for taking a serious look at non-communicable diseases took place, and there were 10 districts in the entire country, about 600 districts were to do this pilot. And in 2010-11, the program gets rolled out, and in totally in 100 districts of the country, and 5 of them in my state of Karnataka. And these are the 5 districts which are of matter of concern and which are going to do as a subject study now. And 2014-15, the 20 most districts out of the 30 districts of the state is now brought under the NCD program. And 2017, that is this current year, when we close by 31st March 2018 is our financial year close, we are planning to bring the remaining 10 districts back in. And also the Karnataka state on 1st November 2017 was the first state in the entire country to announce the universal health coverage program, which is an ambitious plan, the first state in the country to take it. Just like Gavin told, this is an economist, sort of a map illustrating where India looks like, it's nation within nations, and the state of Karnataka is here. I don't know where the pointer is. Yeah, here. This is the state of Karnataka. It's about a 1.91 square kilometers, with size of population size equal to that of Italy, it's about 60.4 and 62.5. And then in terms of size, we are equal to that of UK. And so we are a large economy on service and service sector and agriculture sector. But in terms of health indices that we look at, the maternal mortality rate is about 133, which is seriously a little higher on this. The public health expenditure is about 1.04 billion, and per capita is far less than what it is shared. It's $16.56 and is spent on public health expenditure. And so this means that there is even the coverage of insurance. In terms of the insurance which I'm talking about would be any sort of health assurance as well, where the state government funds it. If it's pure insurance, it will be just 6% of the total population is covered under any sort of insurance there. And this is how the fact file looks like. The subject districts that we were taking were the first 5 districts which were rolled out in 2010-11 for the NCD program, and the total population of the districts were about 8.29 million in total, and that were the 5 districts of Udupi. To just get in this is a coastal district of Udupi, then we have the district of Chakmangalur and Shimoga, which are the districts which are hard to serve area. They are the Western Ghat and hilly region. And then we have 2 plain districts, that is one is Tumkur and one is Kolar, which are the other districts in the southern part of the state for which the program was rolled out. And how does the health landscape look in the country? Unlike other countries, the health landscape is predominantly dominated by the private health providers. The scenario is about 72 to 79% is all contributed by the private healthcare providers, and a small about 28 to 29% is what contributed by the public health facilities. Wherein the cost, when you see, the cost of availing care is far lesser. This is the National Sample Survey report of 2014, the 71st round, which showed that there's a 4-fold increase in the cost on availing the service, but people still go for these private healthcare providers. And we were going to, in the during course of time, we're going to discuss a little about this. The health system, just we will give a brief how the health systems work here. At the community level, we have what is called as the accredited social health activists, or the ASHA. There's about, for every 1,000 population, we have 1 ASHA, and at about 5,000 population, we have a sub-center, which is 2 health workers. One is the male health worker, and the other one is a female health worker, as it is re-designated now, or she's generally popularly called as the auxiliary nurse midwife, or ANM. And then the primary healthcare is about for a 30,000 population. We have a primary healthcare facility which has about 4 pillars. That is a medical officer, then you have a lab technician, a pharmacist, and staff nurse. And you have the for a 100,000 population, you have a community health center, a sub-district level hospital. Then you have the district hospital and the tertiary. The public health program, which is also popularly taken up by many of, which has been catering to the many of the public health needs of the state, are more handled with the RCH program, which is an RCH which includes the RMNCH plus A, which is reproductive, maternal, neonatal, child health, and adolescent health as well. And the immunization program, which includes the popular pulse polio program, which we have done pretty well in the country. Then you have health system strengthening, which includes the human health resource as well as the physical infrastructure resources of the healthcare facilities. Then the next in the predominance would be the communicable diseases like the vector-borne diseases, the tuberculosis, the leprosy, and still some of the neglected tropical diseases, which all come under this umbrella. Then the non-communicable disease is at the last rung of the whole thing. The problem is paramount, but the importance when you see this, and then when we see with the finances, you'll understand. Of which one of the major components, the 2 important components are the NPCDS, National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular, and Stroke. Then the National Program for Health Care of Elderly. And it also has other smaller components like the mental health program, the tobacco control program, the blindness control program. So the objective of this particular NPCDCS program is on the health promotion, giving importance on health promotion. Basically, it's a chronic care that needs more amount of emphasis on that. The second is an outreach camps to make sure a camp approach is done, and so that you try to capture through opportunistic screening. And next is management of these diseases, also one of the, because you don't have a cure, it's a chronic illness which needs a greater deal of money, and effort has to be spent on managing these diseases. And to manage these diseases, you need to build capacities at community, capacities at the patient level, capacity at the healthcare level. The next important aspect is also to support with diagnostic, because it has a constant treatment and constant diagnosis is the effective way of managing this particular disease. So it is support of diagnosis and the cost-effective treatment to ensure that the medicines and availability of quality medicines are also ensured at this level. And development of a database is the most important thing, because follow-up of these patients are the critical part of success. And if these are the important, though the vision of the project or the objectives of the program are really very impressive, but the study was to see how far have we reached in doing this. So in terms of NCD program, which I'm talking about, will limit up to hypertension, diabetes, and to a very preliminary level of cancer screening, which would be only visual inspection for cervical, breast, and as well as the oral cancer. So the NCD treatment or this program runs from the subcenter level with the screening using a glucometer for blood sugar level, as well as the BP apparatus for the BP, blood pressure. And then the primary care is where you have a medical professional who's going to attend the patient, wherein you have a preliminary manual diagnostic methodology, as well as medicines are administered at this level. Then you have a special rung of a niche of NCD clinics, which are created at 100,000 population, which is about in a radius of about 40 kilometers each. And so this would provide a physician, and it is anticipated to provide a physician, then a confirmatory diagnostic test, medicines are administered here. Then you also have a counseling facility in order to help people cope with this problem. The next level, which is the apex level at the district level, has a multi-speciality facility. It has a confirmatory test, a medicine, a counseling, as well as something like a cardiac care unit, which is there, a 4-bedded intensive care cardiac care unit is there. Physicians are available. My project, which we were looking is, as this program, which was rolled out in 2010 to 2017, has achieved what it's supposed to achieve? Are there any lessons to be learned? If so, what? And how are the course correction to be in fact given? And what are these course corrections? And so the objective was to understand the challenges that are faced from the implementation point of view. We already had some reports and research that was available in the literature, as well as some research groups who were working in these districts on the access to medicine, with patient care, and how the patient perception. So barring the patient part of it, the entire implementation chain was trying to understand how the implementation chain works, and how was the policy changes and implementation is working here, and what are the feasibility that are there for making these policy changes, and next, what would be the recommendation that we could give to the policymakers to bring in that necessary modification or course correction if there are. So the methodology, what we followed was a mixed method using both qualitative and quantitative. The qualitative data was from the secondary data that was available from the department, the published data which the department shares, and the qualitative work was a part of the in-depth interviews with the policymakers and the implementers at the district and up to the PHC level, then focus group discussions with the ANMs and the male health workers who are at the community level. So the screening has happened from 2010 to 2017, and this is where we are. In which about 66% of the population, almost like 2/3 of the population, seem to have screened, but the people who are detected with positive is about 7.16%, and the people who are put on treatment is as low as about 4%. That means that you are missing a large spectrum of this, despite having such massive screening, and despite that means that either these people are left out of the run, left to complications which are going to come with a higher cost to this exchequer to us in the later dates, or they are pushed to out-of-pocket expenditure and sometimes even a catastrophic expenditure. So the entire implementation challenge happens at the policy level, which is the federal structure, and then it moves up to the state level with the policy and the funding, then it moves to the district level for the money is moved to the district level, and there you have the human resource hiring, the funding of the medicines, diagnostic kits, and then these diagnostic facilities are now extended up to the PHC level and the community level, where in every ANM, it's about 8,800 plus ANMs who are given with a BP apparatus and a glucometer to test with the glucose strips and necessary inputs, and all these look at this. There are some challenges. We found that there were delay in the release of funds. There were a lot amount of issues with respect to upkeep of maintenance of equipment and the supply of consumables for these equipments. And these were some of the challenges which we, in fact, are going to discuss later. So the process is, I've explained that the person goes at the sub-center, preliminary opportunistic screening takes place, then the primary healthcare center, the medical officer tests, and again sends a patient to the NCD clinic, and the NCD is where the confirmatory test, and the patient is sent back to the PHC. And mind you well, from the village level to this NCD clinic, it's about 40 kilometers anywhere average, and so that means that it costs money and geographical separation for people to catch. Where in the primary healthcare center, it's about 10 kilometers away, could have been an effective way to use with their medical professional available. The next important thing I'm going to look at the lens of the 6 building blocks of health system strengthening, and each one of them will be discussed in brief. And so the first block, which I'm looking at the lens of service delivery, there is all levels, from the community level worker to the highest policymaker, did acknowledge the fact that, and these are the preliminary findings of my transcription is still on, and I have 122 interviews to be transcribed. So this is what I have noted down in my discussions in these places, that the awareness in the public is really high. People are aware of the NCD thing. There's a demand for the NCD services. People, when the ANM goes, they really ask, please check my BP. And there are other challenges also there, because it's not a population-based screening. That means you are leaving a lot of people. There are people who are in these villages who are either, the concentration is more towards the sub-centers, headquarters, and the villages around it. The farther villages, about 5 kilometers, 6 kilometers, are anywhere left out because either they don't come to the service, or these ANM are mobility issue which is not able for her or the male health worker to reach. And so that means inadequate coverage of these people, because the coverage happens at 10 in the morning to 4 in the evening, but these workers leave at 8 in the morning and come at 6, and so that means that almost like half of the population is left out of this basket. So the detection of new cases therefore is poor. It's only the same cases round and again they're seeking treatment, but the real challenge is to how do you bring these unserved population back into your fold. And the health workforce of the health systems are also quite shaky, because about 47% is the overall vacancy, and where in the NCD clinics, which was an ambitious project to create clinics at all levels, but since they have not been able to attract good human resource of medical professionals in these places, either the attrition level is high, because the average time which a doctor stays in the facility is just 9 months, and then you'll have to seek again, find another doctor for that. And so these are some of these. And ANMs at the community level is bogged with about 14 different vertical programs, and she spends, whenever asked, the real question is, how much time do you spend on doing real clinical service in the field? She tells, in a day of 30, about 10 if I get, I'm lucky. And that means other 15 to 20 days are going on doing reporting or attending some administrative works and other things. The same case is with respect to the medical officer. So this is also have a very important implication on the people utilizing these capacities, because the OPD load is good and it's sizable, but one is the time constraint that is not available for them. And second important aspect is that these people do not have quality time, because many of the times either they're going into a meeting or an administrative job which will pick up the clinical time, and that means that reliability of service availability is a big question. That's why people would not turn up to a facility like this. The second important thing that we in fact worked also in the third important thing which I looked is the MIS system. The MIS system seems to be still manual reporting. It's not integrated with the HMIS. Those 7 years have passed and we have not integrated with the health department HMIS, which is robust for maternal and child health tracking. You have an online mechanism of tracking a mother and child using an SMS-based method or a text-based method, but we still left out this particular thing, which is the more important serious situation. And then that means that you know that you track any patient that you are treating. There's no way to track the performance of the personnel or the people who are in the treatment as well as the care providers. And so this means that there is going to be a lot of gap with whatever we are doing. And it's like running on a treadmill. You run, but you don't reach any place. And so that's the reason. and there were some innovations that were seen in some of the districts where the district themselves had taken some SMS-based or text-based sort of calling patient, following up during calls. The next important was availability of medicine. This was the greatest challenge till about 2016 and when we started the online indenting system. Now, earlier it used to be a set of money that was given and then told the PHC can only take whatever is available. But now with the online indenting system, the spectrum of medicine availability has increased and people have been able to access medicine. Not one facility out of the 40 plus facilities which I visited did record any shortage or the stock out of medicine, and that means that this is impressive, and this has also created more amount of footfall into the PHCs because the availability of medicine is the most important critical part of this, and the diagnostics that are available here. And then financing, there's a lot of delay, and just to mention that the amount of money that is spent on NCD is just 1.5% on an average, and so out of the total health in the primary and secondary health care. And this means astronomically you can understand what is the importance of the program, and despite so much amount of money. And we still have this RCH hangover, what I call the unfinished agenda. The RCH gets 78% of the total funding is only for the RCH program. That means it's really cash rich and then it's doing good, but now we have another bomb that is coming just behind us. And so the guidelines were also not there proper for the people. There was money sent and people were waiting for the guidelines to come and money was not spent, or there were inordinate delays. Like the first release of this year's budget was done during somewhere in November to December, right? So that means you can understand from April to December, the whole starvation fund would have been there, how the program would have taken off. So the leadership, which is at the whole epicenter of the whole building blocks, is the gaps. Again, the state level, there isn't a dedicated program officer for this. That means the program officer is quite frequently shifted, so that there's not much emphasis given because this is one of those 8, 9, 10 programs which are there at the bottom of the pyramid. And then there were also the district level, the officer who heads it has another 6 other programs to handle along with this program. That means the focus will be almost a little less, and then there's a high attrition rate of medical personnel because they are put into other duties and responsibilities. So there is also, in fact, as I told, the predominance of private sector is more important, more to be taken cognizance of, but the way to in fact work around with or have collaboration with private sector is something which has not been strongly seen in the primary and secondary care, but in tertiary care we have been able to achieve that. So the next steps is, of course, to transcribe the whole thing and then code and analyze them and then also publish them and also present that the proposed Duke India program, Duke Health event in Delhi in 2018 December. And as I go back, I would like to first share the findings with my team, the district level team, so that they will be able to do a sort of an introspection. And finally, the whole program, is it equality or equity? What are we looking at? And so I'd like to close with what the apostle of non-violence told. It's health that is the real wealth and not the pieces of gold and silver. Thanks, Gary, for that.
Daniel did something unusual, which we weren't expecting, is that he came to do his fellowship. It was a short fellowship for 3 months. And then halfway through, he announced, I'm going to go back, I'm going to do some interviews. And we're like, that's crazy, but go for it. And off he went, and he did 120 interviews in like a week. Like, 20 or 30 a day. It's incredible. Amazing study. We can take a few questions. I'm conscious of the time. I'm going to just ask one, which is, there's this massive disconnect. You showed burden at the beginning, and then one of your slides says the state is spending like 1.3% of its budget on the disease that is causing so much of the burden. Why the disconnect?
The priority setting is what is the most important thing, and because historically when we have the reproductive and child health have taken, like we had almost like 20 years of legacy of RCH program coming, and then you have the Millennium Development Goals, which was focusing on IMR, MMR, TFR, and so all efforts were put on that, and this was somewhere lost in the entire background. And so that means to say that it is now slowly moving. If you see the amount of money that's coming, in the absolute terms, it's about $2.2 million per year, but still small. But I'm sure it's the agenda is now set, and there's a lot of recognition. But for tertiary care, we have a sizable amount of money care. But this is a lopsided way of looking at it. You wait until people to come there and then spend more money, wherein that same money would have been invested on the previous. That would be some of the things that we're going to discuss in the paper.
Next week in both my undergraduate and master's class, we're going to talk about agenda setting and why issues rise up the agenda or language at the bottom. So that's a very nice example. Yes?
So that was an amazing talk. Thank you. I'm guilty of the reproductive health hangover, so I love that phrasing. But I wanted to know, I mean, particularly with the youth population and the inactivity, all of the issues you were talking about affect fertility. So has there been any talk of combining the reproductive health movement with the NCD movement to talk about how you can work together and potentially reallocate some funds?
Oh, well, in terms of the adolescent health, yes. We are now trying to focus on having yoga, because that's one of the focus in the country, and India is very strong in yoga.
You have a minister for yoga?
No, we have.
You have somebody. You have like a. Okay, I better.
Thank God, no.
He's not a minister. What is he?
Very close to the president.
Okay, he's somebody.
Okay. He's a brand ambassador for yoga.
Brand ambassador.
And yes, it is quite serious in the adolescent health that we are trying to look at these particular. Situation wherein we could reallocate, making sure that there is more amount of discourse on physical activity and trying to make sure that you don't get these population pushed into that particular bracket later.
There's a really amazing intersection potentially that could be leveraged, however you say it, which is that, and this is Seth Berkley who said that to me, the head of Gavi. He said that with HPV vaccination, Gavi is now reaching adolescents. Many of these adolescents who have never had any healthcare access at all. They've never had any contact with a healthcare practitioner. And wouldn't it be amazing if we considered that as an opportunity and a platform for other things? You know, physical exercise promotion, diet promotion, menstrual hygiene. There's an amazing opportunity if we can combine and converge. Exactly. One last question from the Claymeister.
Thank you guys both for your presentations. They were wonderful and very informative. So my question for you, Victor, is if you remember we talked about in class, and I'm sure you're aware since you're from India, there is just incredible amounts of air pollution, especially around New Delhi, but in India because it's so rapidly developing and industrializing. And we've talked about the links in the studies that have come out recently linking air pollution to all these NCDs. And with the work you've done here, do you think you can leverage what you've found as far as the disconnect that Gavin's talking about with trying to figure out some way to maybe create some policy movement for air pollution control, or any ideas for that?
Well, yes. In fact, the state is quite seriously concerned with the air pollution, air quality level. And this is more amount of situation that we are more in the urban side of areas, and wherein we are looking at less polluting vehicles, and then also having cleaner fuel and using electric vehicles. And there's a new policy that's coming on the electric vehicle policy, which has just been in the formulation stage in 2017. I think next year we should be rolling out. And then the public transport is now greater move towards electric vehicles or using biofuels like ethanol-based sort of thing. So this is moving, but I'm sure these are baby steps towards the direction. But it will also strongly, in fact, look. But this is how Delhi went in through a lot by using CNG for reducing the pollution level. And so I'm sure we have already an example.
Also burning of crops yes. in Haryana and all. There's going to be an agreement on that between Punjab, Haryana, and Delhi government. So that will.
The incinerating of the crops,
just like
leftover, the crop leftovers.
Yeah. And they're phasing that out.
Yeah.
That's great, because that's so much.
That was almost an international news when it came in through. That's a great question.
Thank you so much. Thank you all of you.